Okay.
Divish.
Okay, you can start. Okay.
Okay, can we start again?
Yes, can.
Okay, apology for that small hiccup. Okay, so we want to go through a few agendas. So I have just a brief overview and what is the robotic timeline, what is the role of robotic surgery in the COVID pandemic, and what is the robotic surgery trend, and what part of robotic surgery and what are the components of robotic surgery, what are the common procedures, the benefits for the surgeon as well as the patient, and robotic surgery for malignant condition, and what are the thoughts of different colleges with regard to the robotic surgery, and a few quotes for my patient that I have performed in Liverpool Women's Hospital. So I'm very proud to say that prior to coming to Malaysia, I developed the robotic surgery program for gynecology and gynaecology in Liverpool Women's Hospital. It's a big task developing a new robotic surgery program in the middle of COVID pandemic, but it was the right time, and successfully the program was established, and I did my first robotic surgery in Liverpool Women's Hospital for grade 1 endometrial cancer on the 14th of October 2020, and the program is running smoothly so far. So an overview, how do I take away this one? An overview. Okay, thank you, Dinesh. So minimal invasive surgery, it's a surgical operation is done through small incision. So non-robotic traditional minimal invasive surgery is also known as keyhole surgery. It is very important to understand that the robotic surgery falls under the umbrella of minimal invasive surgery. So what is robotic surgery? It is a surgical tool. It's a new generation surgical tool, which allows the surgeons to perform complex procedures safely with more precision, flexibility. It has a tremendous control vision mechanism than our conventional surgical technique. So in another way, you can indirectly say it is an advanced laparoscopic surgical tool. Okay, that's what people need to understand. Robotic surgery is nothing different out of the world. It's part of the process following a laparoscopy. So it has been there since 1985. There's so many inventions. The first Da Vinci robot was in 1997, where they have done tubal reanastomosis. And the first hysterectomy with Da Vinci was in 2005. For the robotic surgery and COVID pandemic, as I said, it was a very useful platform when I developed the robotic surgery program in Liverpool in the middle of COVID pandemic. Especially, it was very beneficial for my gynaecology patients. If you take into the SOP what in relation to COVID pandemic, we had fewer staff needed in theater, better maintenance of social distance in the theater, and shorter inpatient time. Some of the patient, if they have surgery 8 o'clock, they even go home 8 in the evening, and the patient being able to go home on the same day or the day after. So that was very useful during the pandemic. So these are the trends. So look into the graphs on the right-hand side. There are general surgeon, you have the gynecology, and you have the urology. All the disciplines are upward trend. So it is expected in 2025, you can see how it is being projected. All the disciplines are taking into part. Now, the cardiothoracic team has taken robotic surgery, the ENT has taken the robotic surgery, and in regard general surgeon, the colorectal surgeons have taken dramatic input into this robotic surgery, especially when we perform severe complex endometriosis patient. Is amazing how the general surgeon, the gynecology, the urology, the whole team comes into one robot and perform the surgery in one discipline. Multidisciplinary approach with robotic surgery is amazing. So on the left is the traditional way of opening a patient. You can see how big is the BMI, and you can see on the right hand side the beauty of the scar compared to the left hand side That's what we want. Minimal scarring and give the best outcome for the patient. So what are the components of the Da Vinci? The first one is what we call the patient card or surgical card. And then you have the vision card, which gives you for the assistant or the nurse, scrub nurse to see. And then I have my surgeon console. So these are the components of the Da Vinci. So the Da Vinci system operates with cutting-edge surgical technology, decreases the need for an open surgery. Remember, it does not act on its own. It will not work without me. What I meant is without the surgeon. All the movements are controlled by the operating surgeons. The beauty is it has the 3D high definition vision, magnified 10 times. So you can see 1807, you have the first laparotomy, and then we moved to straight stick laparoscopy. In 1989, we did the first laparoscopic hysterectomy. And in 2005, we did the first robotic assisted hysterectomy. So that's the progression of the surgical tool to give the best outcome for the patient. So the common robotic surgical procedure for gynaecology. So in UK, around 95% all endometrial cancer patient, plus or minus pelvic lymph node sampling, plus or minus para-aortic lymph node sampling, all takes place with the robot. So we take robotic total hysterectomy plus or minus BSO, as I said, for uterine cancers, and in cervix, very early stage, as well as precancerous stages. We undertake lymph node sampling, and we also do sentinel lymph node study for endometrial cancer with the firefly technique. When you inject the ICG dye, it's amazing, it's beautiful. You can do the lymph node mapping and take the sentinel lymph node. And it is very useful for fertility sparing cervical cancer treatment, robotic trachelectomy, and staging in assumed early stage ovarian cancer. It's a new platform that the robot is being used, and robotic surgery for ovarian cancer. So the benefits of robotic surgery for surgeons: revolutionary anatomical access. You can go anywhere. I can reach all the quadrants I want to go. Greater visualization, optimized for complex procedures. Its dexterity is amazing. The precision is amazing. Ability to remove the cancerous tissues. Easy access to hard-reach areas. Increased proficiency. I can rotate wherever I want to go. 540-degree rotational of instruments. The best thing is it is tremor filtration, reduced fatigue, beyond the human hand. That's what I would say. So now, what are the advantages for the patient who is undergoing this robotic surgery? Less pain, smaller incision, reduced need for medication. I just managed with a simple paracetamol. I discharge my patients, majority of them with simple paracetamol, minimal scarring, reduced bleeding. I tend to say a teaspoon for my hysterectomy, faster recovery, low risk of infections. It is proven fewer complications. They can return back to daily routines quickly. Excellent cancer control where indicated, shorter hospital stay, and less blood transfusion. For the technology, you can see the definition of the image is amazing, 10 times. You know, it is just literally in front of your eyes. You can see the nerves, the blood vessels. You can gently push them away. And then the sentinel node with the firefly, with the ICG dye, you can see and do the sentinel lymph node study. And basically, it's an ergonomic comfort is amazing. You know, I can sit down comfortably and do the surgery. You know, there's no fatigue when you do robotic surgery. So now let's take one by one. As I said, the most common indication for gynaecology is endometrial cancer. As I said, in my center in Liverpool, majority, 95%, most of the endometrial cancer patient been operated using robot. So with the systemic literature review, it is proven that the robotic assisted surgery is far better than the laparoscopy hysterectomy for endometrial cancer. What are the advantage compared to the laparoscopy? Estimated blood loss is lower, length of stay is lessened, less rate for conversion, less incidence for intraoperative complications, incidence for blood transfusion is less, 30-day post-op complication is less compared to laparoscopy, and 30-day post-op mortality is again less. When you compare with the laparoscopy straight stick, when you do a sentinel lymph node or pelvic lymph node dissection using a robot, you will have a separate comfortable zone. It is so easy to do pelvic lymph node dissection, especially when we have a BMI of 50. In majority in UK, the BMI is above 40. So, just imagine going to the pelvic area to do a lymph node dissection with a straight stick, how difficult it is. Robot just makes your life so easy. Again, there's another study has shown definitely it is far better when you compare with the open hysterectomy. Again, reduce estimated blood loss. I think with open hysterectomy, one would say around 300 to 500 ml. And then for my robot cases, it is around 15 to 20 ml blood loss. Again, the length of stay, when you have an open hysterectomy, they tend to stay 3 days. Robot on the same day or the next day. Blood transfusion again reduces. So this again shows what is the advantage of undertaking staging endometrial cancer with a robot, compare laparoscopy and laparotomy. Again, the mean estimated blood loss, length of stay, overall percentage of complications was significantly lower in the Da Vinci cohort compared to the laparoscopy and open cohort. It is in the literature. Again, Da Vinci total hysterectomy with staging appears to be safe and effective surgical alternative for patients with early stage endometrial cancer. Now, ovarian cancer. So in standard current practice, what we do, conventional surgical procedure is a midline laparotomy. We take the ascitic fluid, we remove the cervix, uterus, both tubes and ovaries, removal of the pelvic and para-aortic lymph nodes, omentectomy, plus or minus appendix, and removal of all visible disease. What is the disadvantage of what we are doing at present? Long recovery, back to routine activity, longer length of stay in hospital. It is more expensive, physio, pain management, stay in the hospital, ICU care or CCU care. So now the robotic surgery has been introduced, presumed radiological staging, early stage of ovarian cancer, no peritoneal disease, then robot is a surgical tool that can be used. We were able to access to the pelvic, abdominal, and all the quadrants that we want to go. So what is the advantage of robotic versus laparoscopy? Less conversion to open, less blood loss, less post-operative pain management, and same survival outcome. I'm talking about early stage. And again, in each and every case, individualized patient selection is vital. You need to select the right patient for the right surgical tool. Now, for cervical cancer, minimal invasive surgery was well recognized. But since 2018, following the LEC trial, minimal invasive surgery has been shown in that trial that poor survival outcome compared to laparotomy. This trial was in relation to laparoscopy approach. There's no randomized control trial on robotic surgery. But do you remember at the beginning I said robotic surgery falls under the umbrella of minimal access surgery? Since this trial, different institution has different approach, but the trial has been given, how do I say, it is a good trial. So there is a reduction in minimal access surgery for cervical cancer. Again, it all depends on the patient, where, how early is what stage is the cervical cancer. So patient selection again is important, individualized tailored patient treatment. And you explain to the patient the pros and cons of open laparoscopy, and robot, and then give them the choice what they want, and then you give them the best. Now let's see what the colleges says about robotic surgery. So the RCOG clearly states that it is, in recent review, hysterectomies compared operation conducted by robotic surgery and laparoscopic surgery. The results showed that robotic surgery was quicker, reduced hospital stay of patient, and resulted in less blood loss. Now let's see what the Ransock says. Robotic procedure falls under the minimal invasive surgery and considered advanced laparoscopic surgical tool. So robotic assisted surgery has been explored in a number of procedures and may be an acceptable form of treatment for a variety of conditions. Now let's see what the American says. So robotic hysterectomy generally provides women with a shorter hospitalization, less discomfort, and a faster return to full recovery compared to our traditional approach, open and laparoscopy. So currently we have 5 pots goes into the tummy like a small smile shape. This is going to go away and we're going to use just an umbilical pot where all the arms of the robot will be into one. So this is, some institutions already started with this, but we have not reached to that level yet in Malaysia. So in future, or we already started in relation to the technology. So we already used the ICG dye inflorescence to find the sentinel lymph node. And there will be a plasma jet technology in future. You can put into the MRI picture into the robot screen and do under direct vision where you want to go. In future, there will be specific antibody. You can detect where is the cancer tissue and literally take the cancer tissue away. So this is what the future is going to be. So I have written few quotes from my robotic patients' experience. I'll just go through one by one. This is what the
Robotic patients. You operate on robotic patients. Okay, never mind. It's a lame joke. Go on.
Yeah. It's okay. So after my surgery, I had no pain and I was able to sit up and move about. I only had pain relief for 24 hours. This was only paracetamol. My incisions were very small and have healed quickly. Once home, I could sit in a normal chair and did not need much bed rest. I could walk up and downstairs as normal. I feel having my surgery this way has been the best outcome for me. Another set of experience. I know I'm healed physical problems, but the effect it has mental health is absolutely amazing. After I got home, I only took paracetamol. Can't believe I had a major surgery. I would tell everyone who was offered robotic surgery to accept without a doubt. Thank you so much for what you have done for me, not only my physical health, but also mental health. What does this mean? Patient value equals to efficacy and invasiveness. From the surgeon point of view, patient value is the paramount, first most important value, plus ease of use for me, dependability, shorter length of stay. What is the hospital value? Patient value plus surgeon value plus the economic benefits for the hospital. Economic value equals improved outcomes plus fewer complications, reduced length of stay, fewer readmissions, faster return of patient and staff to normal activities. This is what it means for me, the robotic surgery. So, robotic surgery, I just want to give a quote from Dr. Friedrich Trendelenburg, because Trendelenburg, he always tilt the patient down to our Trendelenburg position for the robotic surgery. There are numerous technology outside the immediate interest or view of surgeons, which will either require surgeons to implement or which will impact upon the way surgery is performed or possibly even replaced. So thank you for giving me the opportunity. I love my robot who is assisting me to provide the best and safest individualized surgical treatment to all my patients. Thank you.
Okay, that was a really short talk. Okay.
Okay.
Are
Short and
there
sweet.
any questions? That's good, because it's been a very heavy week for all of us. The hospital is crazy. Any questions at all? Okay, can I ask, you know, when you do keyhole surgery, how do you take out all the organ parts? through
Okay,
the-
so with the, I mean, in general, with the keyhole surgery, you release the tubes, ovaries, the uterus and cervix, everything comes down below through the vagina. So you take all the structures through the vagina for the endometrial cancer. And then you
Oh,
close the vagina bag.
I see. So do you need to mince all the organs or the
No,
tumor?
no, for any cancer patients, we don't do any destruction to the tissue. You take as a whole.
Okay, is this possible in laparoscopic surgery? No, right?
No, you can still do laparoscopically as well. You release all the structures and it will come through down below through the vagina.
Oh, but most times I've done surgery for fibroids, and it's through the abdomen. It is
Yes,
like,
so for benign indications, let's say if you're doing myomectomy, then you can use the morcellator, put inside the bag and morcellate the fibroids inside the bag. So that would be the way to take it through your umbilical point.
so it is morcellate in the back.
Yeah, that is for the benign condition, not for the cancer tissues.
Okay, but in the US, from what I read, this has been laparoscopic technique with morcellation is not allowed.
Yes.
Is it true?
Yes, not for cancer tissues. No one will morcellate any. Oncologists, we don't morcellate any tissues at all. Only for benign condition, you can morcellate. Even then, please, please, please put inside an endo bag and morcellate inside the endo bag for the benign condition. Let's say, for example, a patient wants to have a myomectomy. You perform an MRI, make sure there's no sarcomatous changes of the fibroid, and then you offer them myomectomy with, again, take the fibroid, put into the endo bag. There's a special endo bag for morcellation, and then you morcellate inside the endo bag.
Okay, I'm asking this question because it's actually me. So
What is it?
I did a surgery for fibroid in 2013.
Okay.
And they morcellated, and then in 2015, I was cycling and hit by a motorbike, and I found that I had a 9-centimeter tumor. It was a sarcoma that was stuck to a band. I don't know what band is it. What band is it? Okay, and there were seedlings everywhere. Yeah, and it was because of the morcellation, and they missed. Of course they missed my diagnosis 2013 completely.
So have they not done an MRI?
Oh, they did an MRI in 2013. They say
Okay.
it was a hemorrhagic
Okay.
fibroid. Yeah.
Okay. So, but did they morcellate inside a bag?
That I never asked.
Yeah. I mean, as I said, first of all, and no oncology surgeon will morcellate any tissues, number one. Number two, if you're doing a benign condition, please, please, please put inside the bag. Then only you morcellate.
Okay. Dr. Sharif asked, may I know how does robotic surgery affect the hours of operation? Is it same, longer, or could it be shorter?
Okay, so in each and every new surgical technique, there's always a learning curve. So during the learning curve, yes, it is longer because you need to learn the docking, the staff has to learn the docking, the anesthetic has to learn about the robotic position and the patient with regarding the ventilation. So everyone is in the learning curve. So during early stage in the learning curve, Yes, there's no doubt robotic surgery takes longer. It is exactly the same. You know, when you do the first laparoscopic surgery after open, again, it is always, you know, learning curve. You also did the same thing. People would comment those days, oh, laparoscopic surgery is longer than the open. I could have done the open surgery in half an hour. So exactly the same. Robotic surgery also is longer during the learning curve. Once all the team member knows what they are doing, then I would say straightforward. There's no delay. It is proven in the studies that it is even quicker than the laparoscopy.
Can it be done under spinal?
No, you can't do robotic surgery under spinal because the patient has to go completely under Trendelenburg position. We have not done. No, I don't think so.
I see. And this robotic surgery, the same Da Vinci robot can do all surgeries?
Yes, see, at the moment, Da Vinci that we have in Sunway XI, it is docking. So docking means how do you put the robot arm into the patient's tummy? So that's what we call docking.
Okay.
So you can do the end-to-end docking where the patient is in the lithotomy. You bring the robot in front of in between the two legs. So that's one way of docking. So with that technique, you can do hysterectomy, you can do pelvic lymph node, you can do lymph node dissection around the bifurcation. But it's very difficult to do para-aortic. Again, you can do side-to-side docking. Again, that docking is useful for hysterectomy, pelvic lymph node, bifurcation, lymph node sampling, not for the para-aortic. For the para-aortic, you need to come from the top end. That would be what we call dual docking, where you have to redock the robot and come back again from the opposite side. But the new model that we're going to have, it has dual docking. You can turn the robot the other way. So that's the beauty.
Tanges, do you mind to stop sharing your slides because I need to share the QR code?
Oh yeah, sorry.
Okay, I have completely forgot to.
No, it's okay, it's okay. Yes.
Okay, so Jackie asked whether how common is robotic surgery currently in Malaysia?
That's a good question. How common it is. So when I explore myself coming back to Malaysia, I was around going to different centers and try to see who has the robot. So according to my knowledge, so far in the private sector, there is one in Glen Eagles, and the other one is what we have here. And in the university, I mean, the government institution, I believe UPM has one, and then UITM has one. I think in relation to Sunway, we have Dr. Tan Yi Ping, who is our robotic surgeon in relation to benign. And I think that's all we have. That's what I know. There might be different surgeons that I'm not sure, other than Dr. Tan Yi Ping.
Oh, but we do robotic surgery for prostate too, right?
Oh yeah, urology is doing beautiful. The numbers is amazing. They do lots of prostate. And then we have knee robotic surgeon as well, the orthopedics. So it's good. Sunway is doing well in relation to robotic surgery. We should be proud of ourselves.
Are we the only, Glen Eagles has a robotics team?
Yes,
okay.
Yes.
So we're not the only one.
No. And the latest news is we're going to get a new technology better than what we have. That is amazing. I'm waiting for our Christmas present. It's going to be in December. It's amazing. Yes.
So what is it called? What is it still robotic?
It is still robotic, but the new model, better than what I had in even Liverpool. So it's amazing. I'm so excited.
Oh.
Yes.
And how much may I ask, is one robotics?
That's it's a secret, Ma. I don't want to explore. Say that in the.
Okay. So basically, if you have, okay, let me go back to this one first. Sorry about this. Oh my God. Okay. So this is a QR code. Even you can scan, Tanges.
Yeah.
When you scan it, you have to use your handphone. There's
Okay.
a MMA app. I don't
Okay.
know whether you have the app.
Yes, I have.
Okay, so you scan this one.
Yeah, successfully.
Oh, where am I? Okay, if you can't scan the app, please message me on WhatsApp, your name, your email, your IC and MMC number. You will also get 5 points for giving a talk. So
Thank you.
basically you get 6 points. Okay. And for those who have not registered or paid for their what you call it, the indemnity insurance, Dr. Shield is actually giving us a promo code for everybody who's watching in, and the promo code is HEARTS2021, and if you put it in, you get 5% discount. Okay.
Okay.
So, oh yeah, okay, I'll give you my number, sorry. So this is my number. Okay. Oh yeah, I'm just sorry. I'll send it to everyone. 012712334. Okay, so this is my number. Just message me on WhatsApp. Please WhatsApp because I really don't check the rest very much. So WhatsApp me your name, your email, IC and MMC number. We'll do it manually. And then any more questions? If not, we will stop here.
Okay.
Yeah. So thank you very much.
No, thank you for inviting me to give the talk, and hope we'll have more patients coming in and more referrals to me to do robotic surgery. I can't wait doing my first robotic surgery in Malaysia. So looking forward.
Okay. Welcome back anyway.
Thank you. Thank you. Thank you.
Okay. And join us next week